So, hello everybody, and welcome to this BEGO Implant Systems web seminar for professionals. My name is Marcio Garcia dos Santos, and I'm part of BEGO Implant Systems education and clinical research team, and will be the moderator of today's session. First of all, I hope you and your beloved ones are all in good health. Before introducing our speaker, I would like to thank Mrs. Angelica Jacob from BEGO Implant Systems Marketing Department for the organization of this session. The topic today will be double crown retained removable dental prosthesis, alternative to All-on-X concept, and the speaker will be Dr. Matej Kulis from Slovenia. Dr. Kulis completed his studies in dental medicine at the Faculty of Dental Medicine, University Zagreb in 2013. In 2015, he started his prosthodontic residence training at the University Clinic in Zagreb, and in 2018, he obtained the title of specialist in prosthetics. In his clinical work, Dr. Kulis mainly focuses on implantology, implant prosthetics, reconstruction of worn dentition, and modern principles of tooth preparation. He places special emphasis on prosthetic soft tissue management, which is also the main topic of his lectures and workshops. Dr. Kulis works as an opinion leader with international companies 3M ESPA, VPI Innovator Cervical, and BEGO Implant Systems. Is author and co-author of several articles, lectures at congresses and workshops in Slovenia and abroad, and performs work in a clinical practice in Ljubljana, Slovenia. Matej, my friend, thanks for accepting the invitation to conduct this session today. As always, at the end of the lecture, we will have a question and answer session with the speaker, and you can place your questions in the question box during the whole presentation. I wish us all a very nice time, and I give the word to Dr. Kulis.
So Marcio, thank you for a beautiful introduction. Thank you for your invitation to this topic, which is quite very interesting topic. This I will present in 3 parts. First parts we will see why is double crown retained option very good. Then I will present 3 cases, and then we have a small discussion where we look scientific data about this prosthetic concept. Okay, so I'm, as Marcio said, Matej Kulis. I'm coming from very beautiful city, capital city of Slovenia, Ljubljana. It is the green capital city of the Europe. So let me start with our topic. Edentulation and severely reduced dentition are still major concerns today. A lot of dentists have clients who have edentulation and reduced dentition. Right now, we have a lot of options to treat edentulous patient and patient with severely reduced dentition. Nowadays, All-on-X concept, All-on-4, All-on-6 concepts, All-on-2, becoming very, very popular. But many of these patients have a very poor oral hygiene. This is the reason why they lost a lot of teeth. So, and they have problems to maintain oral hygiene very, very good. So, the next problem about this topic is how to bridge the hard and soft tissue defects. We can bridge the prosthetically because we want to avoid this, the augmentation. So we need to very procedure to go very fast. So we can bridge these defects prosthetically with bridge with extended sandal, with long crowns, bridge design, or with artificial gingiva applied to the denture or teeth. In All-on-X complex, we have a lot of problems, especially because we have a visible transition between prosthesis and gingiva. So in most cases, in All-on-X, we have to perform bone reduction or tabling, which I quite don't like it, because with bone tabling, we decrease the AP spread, anteroposterior spread. We reduce or deplete the available bone and converse dental defect to dental alveolar defect. So we increase the soft hard tissue and soft tissue defects, and we still have a future bone loss. So what produce tabling? Tabling produce also very big horizontal cantilever, which is very good for plaque, food retention and plaque accumulation. So if we take the data, the most common problem of All-on-X concepts is hygiene related. If we take a look the data of Cavalli and Franchetti, we will see that more than 30% of patients in this study have a problem related to hygiene. We have a big percent of periimplantitis and mucositis. We all know that removable dental prostheses allow much better plaque control than procedures like All-on-X fixed solution, which have a very good survival rate. However, double crown retain, it is very interesting concept, which utilizing the fixed detachable restoration, which allowing excellent plaque control, allowing very good oral hygiene. This is one of the main reasons. And double crown retain supported removable dental prostheses present very successful results in a long-term studies. So if we take a look the data about the implant supported topic about which we talk today, we have a very interesting article which have a more than 10 years follow-up, and we can see perfect result. We have a survival rate about the 98%, and we have a very low percent of periimplantitis. So oral hygiene, the plaque control is a very good in such a prosthetics solution. We have also study from Sven Rinke concepts which are very similar, which I will present today. We have also very good results, more than survival rate of the implant more than 98%, and we have a very low percents of periimplantitis and mucositis, and very low percent of technical complications. So I can believe that I will present today that double crown retain removable dental prosthesis is a very good alternative to All-on-X concept. And the first case which I will present today is implant supported double crown retain removable dental prosthesis. Here is the patient which the general dentist sent to me to find the prosthetic options. So here is the panoramic RTG before the general dentist removed the bridge and extract the teeth. So I decided in these cases, because patient want to very quick solution and we talking about alternative to All-on-X concept, I decided for an implant supported immediate loaded removable double crown retained removable dental prosthesis. Here is my treatment plan. I start with the virtual planing, then I convert the old prosthesis in an immediate loaded double crown retained removable dental prosthesis and go to and after 2 months, I start with the fabrication of definitive double crown retained removable dental prosthesis. If you take the look on the data, we have one very good article for Georgia Romanos, where she made the double crown retained immediate loaded prosthesis retained with double crown system, and he get the perfect result, successful rate more than 94%. So this treatment is safe. So we start with a virtual planning. We decided for a prosthetic driven implantology to produce in minimal invasive way this surgery. So, and here is the first question: what is the right number of implants for a full cross arch restoration? If we take the look, the article of the Skalak and John Brunsky, we see that load-bearing capacity of prosthesis is determined by the distribution of the implants, not on the number of the implants. So distribution is the most important factor. The most important is a AP spread. In between this AP spread, implants is not important. So we have to produce very big polygon distribution of implants. So go back on the case. We started with the guided surgery, flapless protocol. Here is my drilling protocol. I always reduce the RPM for a drilling speed from 800 RPM to 300 because with guided surgery we have a problem with the overheating. So I reduce the RPMs. And why is the flapless protocol very good? We have a less marginal soft tissue and hard tissue loss. We get the better post-operative results, better healing, and less pain. We have also problem. We have a problem with the overheating. So this is the reason why I reduce the RPMs, and we have a risk of perforation or because we have a lack of visibility. After I place the implant, I start with the transferring implant directly after implant insertion. I took the impression technique in a radiographic prosthesis, which I have to perform to make the guided surgery. And I also open small flap. That doesn't mean that I work flapless, but I like to work flapless. That means that I avoid major flaps in such a cases. I just open small flap to augment some small defects of extraction sockets and to reduce some bone exostosis to get a more smooth bone level. After virtual planing and implant placement, I start with the conversion of prosthesis in immediate loaded double crown retained prosthesis. So after impression, the technician used the confection abutments from a BEGO implant system, and over this we fabricated from pattern resin secondary crowns. We converted all prostheses, make the hollows. We performed. We also made the transfer index for placing the abutments on the implants from the radiographic prosthesis. You have to be very careful when you're transferring this confection abutments because you have to find the proper direction, and we apply the definitive abutments immediately after implant placement. I will answer lately why I decided to immediately place the definitive abutments. Here is the temporary secondary crowns, and I bonded with the pattern resin secondary crowns in prosthesis, sent prosthesis back in the laboratory where the technician make the final polishing and to polishing of immediate prosthesis. For immediate loading, we have to go to primary stability. Primary stability is the code to immediate loading. Primary stabilities depend on the quality of the bone, implant geometry, and surgical technique. Especially here, I will mention the drilling technique. I like to use, especially if I have a very poor bone quality, the Versa drills, counterclockwise, also densification method. The results present that increased torque reduce the level of implant micromotion. If you have a micromotion which exceeds 15 to 100 microns, we can induce the producing the fibrosis around the implant, so we will lose the osseointegration. And after that, when technician made the final polishing of the prosthesis, the implant was split together with chair-side relining, and we didn't allow patient to remove the prosthesis for the first days after surgery. After 10 days, we remove this prosthesis, and we get the instruction patient to remove prosthesis only one time per week. During the first 6 weeks, the patient have a soft diet, rinsing with chlorhexidine solution for 4 weeks, 2 times per day. And why we decide for 6 weeks? Because after 6 weeks we get the secondary stability, which increasing the stability of the implants. Patient wear this immediate dental prosthesis for 2 months, and after 2 months we started with the fabrication of definitive double crown retained removable dental prosthesis with zirconia primary crowns and galvano secondary. Here is the workflow of such a procedure, which have a lot of steps. It is a little bit complicated. It is not so easy solution like a all on X concept. And first phase is impression on the basis of the definitive abutments. So we place it immediately after placing the implants. Here is the impression over, which is we took over the abutments. Then we start send this in laboratory. The laboratory produced the registration base place for maxillomandibular relationships and centric relation record. Here is the base plate. We record the centric relation. We transfer the face bow registration, and then the technicians start with the fabrication of primary crown, secondary galvano crown, and prosthesis framework. And here is the second phase in the clinic. We have a primary crown, zirconia crowns in a temporary prosthesis, galvano secondary crowns, and titanium framework. Here is the temporary prosthesis. We use it as an index for cementing the primary crowns on a definitive abutments. We start with a rubber dam isolation, sandblasting, and cemented with the old gold cement, zinc phosphate cements, which is still one of the best cement for a cementing method on implants. After that, we remove the deposits of the cements and apply the temporary prosthesis. Next is the application of alloy primer on galvano crowns, which we apply on the primary crowns. We start, and after that we apply the prosthesis frameworks. Here is the titanium framework. You have to know these thin horizontal slots. We use it because we want to that excess of cements go through these horizontal slots and not going to the connection between primary and secondary crown. This intraorally luting process is very important. This process allows precise and passive fit of double crown retained removable dental prosthesis, which is the one of the I believe the main reason for a very good long-term results of such a works. And we took the second impression over the prosthesis framework and sent it to the labs. And here the technicians start to the fabrication of definitive prosthesis. In between this fabrication, we have to again check the maxillomandibular relationship and centric relation record. This is the reason also why I like this such a procedure, because I can 2 times test my centric relation and maxillomandibular relationships. Here is the wax up trying on titanium framework, and the last phase is the definitive prosthesis. Here is the definitive prosthesis with galvano secondary crown in intraorally luted in titanium framework. Here is the RTG after half year. We have a perfect marginal bone without bone loss. We have all implants in the bone. And here is my answer why I start to using definitive abutments immediately after placing the implants, because I like this one-time-one abutment concepts, because any repeated abutment disconnection and reconnection produce recession of the soft tissue and induce the marginal bone loss. Okay, Olonics concepts many times involve extracting the remaining teeth which are not indicated for the extraction, because we need a solution which is easy to perform, to be cost effective, and to be fast produced. But alternatively, double crown retained prosthesis can combine both implants and teeth with removable dental prosthesis. This is one of my favorite advantages of double crown retained prosthetic solution, because combining remaining teeth and implants, we have several advantages. We have a positive psychological advantage for many patients. We preserve the tactility and proprioception, which prevent functional overloading, and with remaining teeth, it is the best, with keeping remaining teeth, it is the best solution to stop the process of bone resorption of the alveolar ridge. If we look the data, we have a perfect results with combined tooth implant supported double crown retained removable dental prosthesis. We have the success rate more than 19%, about the 100% we have a success for a combined tooth implant supported double crown retained removable dental prosthesis. And here is a study for Krenmeyer, 9 years follow-up, and he have a success rates of implant for 100% and very low presence of periimplantitis and mucositis. And one very interesting article published in International Journal of Periodontics and Restorative Dentistry, 2 case reports, follow-up 22 and 25 years old. They connect, they produce combined tooth implant supported double crown retained removable dental prosthesis. More than 20 years in work, they get a perfect results in a patient with aggressive periodontitis, all implants retained, and they have a just slight bone loss and without any periimplantitis, and just maybe small mucositis. So here is the case where I will present tooth implant supported double crown retained removable dentist prosthesis. This is the case which also general dentists sent to me. Very difficult patient, good or general hair, but problems to accept invasive surgery procedures, high expectations in aesthetics. My treatment plan: root canal treatment on a tooth 3-1, fiber reinforced composite post on tooth 31, temporary acrylic prosthesis, 2 implants at the position 3-6-4-6, and after that, after osseointegration implants, fabrication of tooth implant supported double crown retained removable dental prosthesis with primary zirconia and secondary galvana crowns. I started with the fabrication of post on a tooth 3-1. I sent it to the endodontist to perform the root canal treatment. After that, I made the post and the temporary acrylic prosthesis. I start with the virtual planing. I decided for 2 implants at the position 3-6 and 4-6. If I to remember for what I mentioned, the implants should be placed that we get a polygonal topographic distribution of prosthetic abutments. So if you remember article from Jombronsky and Skalak, they say that the load bearing capacity is dependent on the distribution, not on the number of the implants. The distribution is the most important factor. So we should avoid the guided bone regeneration in such a procedure. We started with guided surgery. Here is my drilling protocol where I reduced the RPM from 800 to 300 RPMs. In meantime, after I placed the implants, I made the apically repositioned flap on a tooth 3-1 to increase the tooth structure to get the ferrule. I made the apically positioned flap to retain the keratinized mucosa, and after 2 months I started with the fabrication of definitive prosthesis. Here is the workflow, how I fabricated tooth implant supported double crown retained removable dental prosthesis the procedure is very similar as in a case which I presented before. It is nothing different. So we firstly start with the impression and transferring the implants to the master cast. I use this surgical guide to check the position of the implants. Again, after the first impression, start with maxillomandibular relationships and centric relation record before the fabrication of primary crowns and secondary galvano crowns and prosthesis framework, centric relation record, and the technician now start with the fabrication of primary crowns, secondary crowns, and prosthesis framework. We have here first try in pattern resin models. I always use this standard confection abutments for such a cases. And here we have now primary crowns from zirconia, prosthesis framework. Here we have a classic prosthesis framework for cobalt chrome alloy. Here is the index to transferring the primary crowns and cementing the primary crowns on a teeth. And here is the alloy primer, which I applied on the intaglio surface in the prosthesis of the prosthesis framework, and I also applied it on the galvano crowns. I applied and cemented, intraorally cemented the prosthesis framework on the galvano crown and took them over that impression to make the final definitive prosthesis. In meantime, we fabricated temporary prosthesis, which is supported on a primary crowns, and technicians start with the fabrication of definitive prosthesis. In this mean session, we took the maxillomandibular relationship again and centric relation record, took again the face bow registration, and the technician fabricated the definitive prosthesis. Here is the definitive prosthesis and final step. This is my first case which I made on BEGO Implant System. And with the guided surgery, we have a follow-up of more than 2 years. And here is the RTG, panoramic RTG, first year of follow-up and the second year of follow-up. We have a stable bone results, so without any bone loss, and we don't have any problems, hygiene-related problems or any technical complication. I have one small technical complication. One time patient didn't get the prosthesis out, so she had to came in my office, and I get it outside. I don't know what happens, what is inside to make this prosthesis to stuck on a primary abutments. And here is the one case, but for this case we need to have a more long-term studies to approve this solution, but I will present. This is the case where we have a very resorbed edentulous mandible, where we can place only implants intraforaminally. Here is the case. We have 2 implants intraforaminally. We took the impression to transfer. In these cases where we have only 2 implants, you have to create border molding process in the individual thrive, centric relation record, and starting same procedure, fabrication of primary crowns, secondary crowns, and prosthesis framework made from PEEK bio-HPP, which I quite careful with this. We still don't have a lot of study which can approve this concept. I tested it after intraoral luting. I started also with the border molding on the prosthesis framework, took the relining impression, and over that I took the impression to send it to lab, and this is final work. If you see, I cover all surface of PEEK with the acrylic, because PEEK can be very difficult for a polishing, and it is plaque absorbable. First peak models from BioHPP, which is castable, pressable, have a lot of problems with the plaque accumulation. We have a lot of prostheses which lose function after 3 years of in practice. So here is the results after 1 year follow-up. We have a still very nice soft tissue around the primary crowns, very good oral hygiene. So as I present in the previous slides, this also solution, double crown retained removable dental prosthesis, is also good solution for intraforaminal 2 implants. The study presents for a follow-up of 10 years very good results, if you remember for a previous slides. Here is my conclusions about the double crown retained removable dental prosthesis. Studies presents very successful prosthetic solution for a dentulous patient and patient with a severely reduced dentition. Why I use always zirconia primary crowns and galvano secondary crowns? Because such a prosthetic solution increase the resistance compared with the conventional double cast crowns, and also leading to and also reduce the worn of primary and secondary prosthetic components. We also have a study which proved that, a study from Sven Rinke, which they follow up more than 5 years, and they didn't find any loss in the retention or damages on a primary zirconia and secondary galvano crown. So this solution is scientifically proved, and patients also very like this white color of primary crowns. They don't like this gold or metal color of primary crowns. It's much more tasteful look when you reduce. Intraoral luting is one very important procedure which reduce the mechanical tension required now that is inevitable in a screwable solution to get a completely passive fit. So this is the option how to get on such a full arch restoration, very precise and passive fit, which reduce the risk of marginal bone loss. It is very interesting article from Oda to read it this year, published in COIR. I highly recommend it to read it if you want to work with a double crown retained system. I suggest to primary crowns have a slight conical design with the angle of 1 to 2 degrees. Why I suggest this? Because with this conical design, we reduce, if we have any mistakes, we can easily remove prosthesis. We don't produce the harmful, very strong retentive forces, because during the pouring and casting, we have a contraction, expansion of the master cast. So this produces small inaccuracy, even though that we perform the intraoral oral luting, which produce completely passive fit. And next topic, very important, material selections. Metal frameworks, titanium or cobalt chrome, have a lot of studies with a long-term follow-up, perfect results. So we have a scientific background for such a procedure. We have also different solution like zirconia prosthesis framework. I have one case on a zirconia prosthesis framework. I also will write the article 1 case report, but I need the longer term follow-up, and then I will present this as a recommended method. We have a lack of long-term studies with the zirconia framing, and also we have a lack of study of the PEEK solution, BioHPP. It is ceramic filled PEEK. It is a little bit modified PEEK. First PEEKs, BioHPP products have problems with the polishing and it is very plaque retentive solution. This have a lot now, a lot of problems. Now they change the workflow. Now we're using the milled, we milled from the blocks this frameworks, but I still quite not sure in this BioHPP. Here is the one patient which come in my office, which have a double crown retain solution, a little bit not perfect design for such a prosthesis. As I mentioned, we need the polygon distribution of the prosthesis abutments, and here they use in this time very advantage material BioHPP to reduce the weight of prosthesis, to also increase the aesthetics and to avoid the using of the metals. But after 3 years in practice, these prostheses have a lot of problems relating, and now I producing the similar procedure, only I add 3 implants in the upper jaw. I add 1 implant here at the position of the tooth number 1, 6 and 2, 6, and 1 implant here at the position of the tooth 1, 1, 2. Drawbacks of such a procedure, double crown retain removable prosthesis: it is technical sensitive procedure, have a higher treatment cost, and requires both clinicians and technician knowledge. It is very difficult for technicians such a prosthesis. That here, if I present, we have a lot of steps. So we should be very careful during all of this procedure. But when you one time learn, it is not so difficult. But we need to increase the knowledge if we want to work with such a prosthesis. And here is my final conclusion: mold the prosthesis to the patient and not patient to the prosthesis, which is today quite common, that extracting all the teeth which can be easily preserved with the advantage periodontal therapy or endodontic therapy, and just add implants to get the better distribution and reduce one removable dental prosthesis. Removable dental prosthesis is a very good option for a patient with severely reduced dentition who have a problem with periodontitis, because that patient have a poor oral hygiene, and we cannot place something fixed solution, because fixed solutions need very good oral hygiene, especially big construction, full arch construction. We have a bulky prosthesis design. It is very difficult to properly clean. With removable prosthesis, they can very easily remove this prosthesis, clean it properly, and apply it again. So we definitely have a less complication related to hygiene, which I think is the biggest problem when you're treating such a patient. During my residency, I work a lot with the patient with the severely reduced dentition and edentulous patients. So I have a lot of experience with such works. So and my suggestion is always to treat with removable dental prosthesis solutions, which can also look like a fixed solution, but it is only easier to maintain. I will also invite you on the next webinar, which we perform in collaboration with the BEGO Implant System. This is my favorite topic. It's prosthetic driven soft tissue management around the tooth and around the implants and the tooth. We will produce at the end of February this webinar, and 2 days hands-on session which we're preparing for 2020 in Zagreb, immediate implant placement and immediate provisional, how to immediately apply the provisional on immediate implants place, how to properly place immediate implant, all about this procedure to graft, not to graft gapping, soft tissue augmentation, and everything. Thank you for your attention. I hope you enjoy this this session, which is quite interesting, because I know that a lot of dentists have a lot of patients with severely reduced dentition or edentulous patient in her in their practice. Thank you very much, and see you, I hope, on the next webinar and today's hands-on session in Zagreb.
Yeah, perfect. Matej, thank you so much for this very interesting presentation, very interesting topic. I would say in an era in the dental medicine when we are only mainly talking about all-on-X procedures and hearing about the term all-on-X, it's always important. It's very important to show and discuss different treatment alternatives, possibilities to the patients, and what you show us today with the double crown retained prosthesis technique. It's a very interesting approach. So thank you once again for sharing with us the presentation and the beautiful clinical cases. I want to say that I like, and we already discussed this, the way you document your clinical cases, beautiful photos, beautiful procedure. So congratulations once again. As Matej was saying, next year we already have two events scheduled with Dr. Kulic. We will have in February a web seminar with him with the topic of prosthetic-driven implantation with soft tissue, and we are planning for Zagreb a 2-day course is also with him. So we are already very excited about next year's activities. Also reminding everybody before the first question about the Clinical Case Award. As you know, we have the 4th edition of the Clinical Case Award. So the clinical cases can be sent to us until 31 March 2022. And all the instructions for sending the clinical cases can be found in our web page. Yeah, comes the first question from the colleague from France, Monica Timianek. Hello, Monica. Nice to have you here. Monica is sending to you, Matej. Thank you for this amazing presentation. This very important alternative to all-on-X approach. So congratulations. And another question that comes, Matej, is when do you decide, or how do you decide if you make the all-on-X approach, so fixed prosthesis? So when you mainly decide that you are planning to go for an all-on-X with fixed retained prosthesis, or to go to a double crown retained removable prosthesis? So how is your clinical approach in this in this matter?
I also produce, I also make a lot of fixed solution on the implants for a full arch, but I deciding about the soft tissue and hard tissue defects. How much patient lost the hard tissue and soft tissue. If I need to get a good aesthetics to apply the pink aesthetic, so if I need to apply the artificial gingiva, then I decide for a removable dental prosthesis, because this prosthesis is so bulky when we apply this pink aesthetics, and it is very difficult to clean around the implants. That is my main driven for taking to make the decision about removable dental prosthesis or fixed dental prosthesis solution. And next, I always check the patient. If patients have a lot of bony defects, which is from periodontal disease, gingivitis, I saw that this patient have a poor oral hygiene. Maybe when patient coming in my office for this half a year, which I making this procedure, they have a very good oral hygiene. But after half a year, when I get this patient on a 1-year recall session, I saw bad oral hygiene. So this is the reason decision how to decide for a removable or fixed dental prosthesis. The main decision is hard and soft tissue diffusion with the only white aesthetic, not artificial pink aesthetics, without augmentation, fixed dental solution. Then if I need to apply artificial gingiva, if I have a hard tissue defects, then to dental prosthesis. One very interesting solution which I do in craft of make the detached calls every 3 minutes, very short 1 minute to remove this dental prosthesis, clean it around very easily, to clean it around the implants, because with the fixed solution I have to open the screws, remove the screws. I need a 1 hour to clean it. So I reduce the chair time with such a procedure, and also with screwing and unscrewing fixed solutions, we also damaging the tap inside the implant or multi-unit abutments. So take in mind that repeatable removing, attaching and deattaching prosthesis on multi-units and implants can induce the wearness inside of implants or multi-units. So be careful about that. We during my work in a clinic during my residency, we have a lot of complications, which is coming to the clinics with the broken screws, with the screws which cannot be detachable from implants and multi-units.
Okay, thank you very much. Also the colleague Marco Patron saying, Dr. Matei, great webinar, and the colleague Ahmed Nagashi, thanks for to make things so clear and for the way you make your presentation. One more question: how many times do you verify the maxilla-mandible relation?
In double crown retained prosthesis, we have we take the maxillomandibular impression relation record 2 times. First time, after first phase, when we took the impression to transfer the implant for the fabrication of primary, secondary crown and prosthesis framework before that. And second one, this is the checking, is after when we intraorally luted the secondary crowns in a prosthesis framework, took the impression over it to get a precise fit without any inaccuracy, and the technician made the new master cast, and over this master cast they produced the new base plate for a maxillomandibular relationship record, so we can check it 2 times. And I think this is one of the advantage. We cannot see this, how many procedure I need to perform this prosthesis. All-on-X is very easy concept, but this concept have also double check of the occlusion, because occlusion is a very important factor for a long-term success of the prosthetics on a prosthesis on implants. Especially prevent marginal bone loss and reduce the technical complication like chipping, the attachment of artificial tooth, broken prosthesis framework, and similar complications, which is quite quite common on a fixed solution. Look, we have a lot of chipping on a fixed solution. First, because patients
One more question here. Which abutment from BEGO Implant
Okay.
No?
I hear you. Could you repeat,
Okay.
please?
Which abutment from BEGO Implant Systems do you use in your double crown retained removable prosthesis?
I used titanium abutment. It is a standard abutment. I can this is the I can give you the ref number of that abutment. It is TIA. It is mark on the implants, and I always use the longest gingival height because it is have a perfect design, starting very narrow in a C zone and then have a convection in a B and A zone. I always use it that solution. For a double crown retained, I don't use the titanium base. I mostly use titanium base for fixed solutions, bridges, single crowns, 3 units, 4 units designs, or bigger units, not for a full arch. I mostly use or multi units, or if I doing the fixed solution for a double crown retain, I use this standard convection abutment with the biggest gingival height. So
Yeah,
we have a step of this abutment epigingivally. So the connection between primary and abutment is around it is epigingivally because this is covered with the prosthesis.
yeah, we are preparing the clinical case messenger with a clinical case of a double crown, and it is what we call the PS TIA abutment, the classic titanium standard abutment. So yeah, that's it. One more question, Matej, is getting back to the first case after the Facebook registration. Then the colleague is asking you. Then you do the cementation. The first case, yeah. Then you proceed with the cementation of the zirconia primary crown over the titanium abutment and the cementation. Cementation of Galvano. Yeah, perfect.
Show again, so we can. Here is the cementation. So here I present this case. Why? Because many of clinician thinks that the immediate loading can be only done on all on X fixed solution. It's not true. You can also do the removable dental prosthesis I present here with immediate loading. And I also like this procedure because after the placing the implants, I always place the guided surgery to get a perfect align between the implants. I also apply these standard abutments, definitive abutments, and I screw it to the full torque, and I leave it. And after, when I start with the fabrication with the definitive, I just sandblast it and intraorally cement it with the temporary prosthesis. With this temporary prosthesis is also indexed for a cementation of primary crowns. I cemented the primary crowns. I hope I answer on this question. Good. If you don't, if you still have anything that is not clear, you can ask me. You please let me know, and I will explain again. So.
Colleagues just asking also which cement you use to make the cementation of the zirconia primary crown, and which cement you use to cement the Galvano secondary crown.
Oh, very good question. If I performing a procedure like I presented, immediate loaded, and I have to I intraorally cementing the primary crowns on standard abutments, then I using the zinc phosphate or polycarboxylate cement, conventional cementing method, because this cement is very visible, it is easy to clean, and I think you don't need to cement with the glass ionomers, which is a little bit more difficult to clean, and it is not so visible. Even though why I use still standard abutments with because epigingivally step, because it is very easy to clean the remnants of the cement if you cementing the primer crust. In a second case like I presented, and third case like I presented, when I took the impression and I fabricated the primary crowns which have already cemented primary zirconia crowns on a standard abutment, then is this cemented in a laboratory, and it is cemented with the multi-link hybrid from the Ivoclar with all these alloy primers. When I cementing the Galvano solutions on the implants, Galvano solution on the implants, just a moment to here. I first applied the alloy primer on a Galvano crowns and intaglio servers of prosthesis frameworks. I use the only one alloy primer, and this is alloy primer from Kurarai Noritake. It is a scientific proof primer, and I use Panavia cement for a intraorally cementing of the Galvano crowns in prosthesis framework. You have to, my advice, please make a note to your technician to fabricate these thin horizontal slots, which enable to access the remnants of the cements at the level of the prosthesis framework, not at the level between the connection of the primary and secondary crown.
Thank you very much. And I believe this was the last question of the session. So yeah, once again, would like to thank you. Thank you everybody once again. Thank Kelly for the organization. Thanks Matei for once again for the very nice presentation. As we said, looking forward for the next courses in 2022. And in November, we're gonna have our last web seminar of this year with Dr. Selene Kuo from Taiwan. The topic will be CAD/CAM restorations, and you'll receive the invitation in the next weeks. So thank you once again, and I wish you all a very nice day. Thank you.
Thank you.
Bye-bye.
Bye-bye.